Hi, everybody. This is Stacy Gallagher. We're going to talk a little bit about hypertension today. So the objectives of this talk are to discuss the pathophysiology of hypertension, basically just an overview of things that you guys already know, risk factors, who and when to screen, complications of uncontrolled hypertension, treatment guidelines. We'll talk a little bit about the JNC8 that just came out a couple weeks ago, and then the role of nursing in hypertension management. So, the definition of hypertension is a systolic blood pressure of greater than 139 over greater than 89 diastolic. You have to get two separate readings at two separate office visits in order to technically diagnose somebody with hypertension. There's a few stages of hypertension. Prehypertension is defined as a systolic blood pressure between 120 and 139 over diastolic blood pressure of 80 to 89. Stage 1 is 140 over 140 to 159 over 90 to 99, and stage 2 is over 160 over 100. So, in order to get an accurate recording of blood pressure, which is super important in taking care of these patients, because we want to make sure that we're getting the most accurate blood pressure that we can in order to make these important diagnoses. Technically, patients should be seated quietly for 5 minutes. A lot of times, patients are sitting quietly for much longer than 5 minutes in the office or in the waiting room. So that should be no problem. But if they've just rushed in from the parking lot, they've been sitting in traffic, you might want to tell them, I'm just going to have you sit for 5 minutes. I'll check your blood pressure after I, ask you all the other questions that we have to go through. You might want to wait until the end of your little spiel. You want to make sure the patient's feet are flat on the floor, that their arms resting on the counter, or if they're sitting kind of on the exam table, you can sort of rest their arm in your arm when you're inflating the cuff. Make sure you're using the appropriate size cuff. If a cuff is too small, it's going to squeeze too hard, and you might have an erroneously elevated blood pressure. And the same other way around, if you're using a cuff that's too big, the blood pressure might not be it might be lower than it actually is. There's a line on the inside of the blood pressure cuff, and it basically shows you where the cuff should appropriately fit. And if that line doesn't line up, then you're using the wrong size cuff. You want to inflate the cuff 20 to 30 millimeters after the loss of the radial pulse. So you can, palpate the radial pulse, start pumping up the cuff, and after you lose the radial pulse, then you want to pump it up another 20 or 30 millimeters. You want to deflate very slowly at a rate of about 2 millimeters per second. This is especially important in patients with irregular heartbeats like atrial fibrillation, because you're not getting the methodical beating. It's more erratic, and it is hard to get an accurate blood pressure when the heart rates are irregular. But if you go very slowly, it's more likely that you're going to get the most accurate blood pressure. The first sound you hear is the systolic number, and then the disappearance of the sound is the diastolic number. If you get something abnormal, it's a good idea to recheck it in about 10 minutes just to see if there's any change. So, risk factors for hypertension, these are pretty self-explanatory: obesity, tobacco use, drug use, high alcohol intake, inactive lifestyle, diabetes, high salt intake, family history, and stress. There's two types of hypertension. There's primary or essential hypertension, which is what most people have. There's no one cause for essential hypertension. It's very multifactorial, and we'll discuss it in later slides, but there's many different mechanisms in your body that kind of go wrong in hypertension. And secondary hypertension is are caused by other things that can be treated, and a lot of times the hypertension will resolve. So intrinsic renal disease, such as like nephrotic syndrome or something like that, renovascular disease. So renal artery stenosis is one of those things that can cause this. Mineral corticoid excess, which is things like aldosterone, and that's where some of the medications come in. Sleep breathing disorders, which is like sleep apnea, can cause to secondary hypertension. Less common, pheochromocytoma, which is a tumor that forms on the adrenal glands. Glucocorticoid excess, so cortisol, which is where stress comes in. Coarctation of the aorta is a congenital defect where in the aortic arch, just as the aorta comes off of the heart, there's a narrowing of the aorta, which makes the left ventricle work harder. And when that happens, a cascade of things happen that cause your blood pressure to increase. And then hyper or hypothyroidism. The pathophys of essential hypertension is very complicated. So we'll just kind of go through an overview here. And again, it's not 100% understood even by the experts. So basically, blood pressure is a measure or a calculation determined by cardiac output and peripheral vascular resistance. And for various reasons, prolonged contractions of the smooth muscle around your arterioles leads to irreversibly increased resistance. And this resistance leads to stiffening of the arteries and in turn increased blood pressure. This is where calcium channel blockers target, and we'll talk more about those later. One of the second factors is the renin-angiotensin system, which is just a hormone mediated, again, cascade of mediators. Angiotensin is one of those. It is a vasoconstrictor. Aldosterone is another one that raises blood pressure in response to sodium and water retention. And this is where the ACE inhibitors and the angiotensin receptor blockers work. Another factor is the autonomic nervous system, which is involved in both constriction and vasodilation of the arterioles, and this is where beta blockers come in. Endothelial dysfunction is another factor in hypertension. The cells that line the walls of your arterioles produce all these chemicals that regulate your blood pressure. So that's one of the other factors. Hypercoagulability. Patients with hypertension exhibit these abnormalities in the blood vessel walls that release these chemicals that we talked about before, that can increase platelet activation, leading to increased clotting, increased viscosity of blood. So hypertension and hypercoagulability kind of go hand in hand sometimes. Which is why these patients are at increased risk for stroke and heart attack. Another factor is insulin sensitivity. There's a cluster of dysfunctions, a lot of times labeled as metabolic syndrome. The dysfunctions are obesity, hypertension, insulin sensitivity or diabetes, and hyperlipidemia. And a lot of times they all go together, and it's termed this metabolic syndrome, that lead to increased blood pressure and vascular damage. And then, a lot of times it's in your genetics. So this is just a figure kind of outlining what I just talked about. So all these different factors: environmental, stress, genetic, central nervous system, cardiac, renal, gastrointestinal, endocrine, they all affect the way that the blood vessel walls contract, and that leads to increased pressure and blood pressure. So what's the big deal? Hypertension is often termed the silent killer because many patients don't feel symptoms. it's sort of a tragedy. It's what I say to patients, that you can be walking around for years having high blood pressure and not have one symptom, but secretly it's doing damage to the blood vessels in your body, and down the road it causes trouble. And that trouble is target organ damage, the long-term effects of poorly controlled hypertension. So it can affect your brain, it can affect your eyes, it can affect your heart, it can affect your kidneys. So, to talk more specifically about the cerebral vascular system as a target organ, long-term high blood pressure basically wears out your heart. So your heart is trying to pump against a pressure that it doesn't like for years and years. And if you think about somebody who's doing bodybuilding and they're lifting weights, your muscles getting bigger, but it doesn't necessarily mean that it's working, especially in terms of cardiac muscle, that it's working at 100%. So patients will end up with left ventricular hypertrophy, which in turn down the road leads to dysfunction and can lead to failure. Long-term hypertension can also lead to arrhythmias. So the left ventricular hypertrophy kind of backs up and can lead to increased left atrial pressure from the increased peripheral vascular resistance. And that increased left atrial pressure is a risk factor for developing atrial fibrillation, which is a very common problem and very difficult to deal with in some patients. It can also lead to coronary artery disease, like we talked about with the hypercoagulability, the stiff arteries, things like that. The damage to the endothelium all can lead to MIs and coronary artery disease. Also, damage to the endothelial walls of blood vessels can lead to aneurysms. And then when you have an aneurysm, which is a weakening of the blood vessel wall, and then you add high pressure to that, you can end up with dissection, which is basically a leak from the aneurysm. And then that can lead to a full-on rupture. And if that's, in your brain, that's a stroke. If that's in your aorta, that's pretty much death. So that's an important, and then peripheral arterial disease. So people can basically get the same type of thing that happens in your coronary arteries, the plaque buildup from those damaged endothelial walls, and the cholesterol builds up and platelets attach. So you can end up with peripheral arterial disease. A lot of times it happens in the leg arteries, and people need interventions for that as well. So the next target organ is the kidneys. Glomerular sclerosis. Glomerular are the little tiny vessels in your kidneys that filter, and those get sclerotic with long-term high blood pressure, leading to impaired function and eventually end-stage renal disease. Ischemic kidney disease can occur, especially when renal artery stenosis, so a narrowing of the artery that enters the kidney, is the cause of secondary hypertension. So the nervous system, obviously stroke is a major concern for people with long-term high blood pressure. You can also get the hemorrhage from a ruptured aneurysm, like we talked about before. But also, without, a catastrophic stroke, you can also get these, over time, the cerebral atrophy that can lead to dementia. And then the eyes, retinopathy, a lot of times we associate with diabetes, but again, with the metabolic syndrome type thing, a lot of these things go hand in hand. So retinopathy can also happen in patients just with high blood pressure. It can lead to retinal hemorrhages, impaired vision, retinal detachments, neuropathy of the nerves leading to the muscles in your eyes. So that's a big deal too. How do we take care of these patients? So, routine labs or tests that you might see ordered on patients, or you might notice are overdue when you're reviewing a chart. You want to screen for the other comorbid conditions. So, you want to check blood glucose. You want to check for anemia, so hemoglobin, hematocrit. You want to check kidney function, so creatinine or GFR. You want to check electrolytes, potassium and calcium are the most important. You want to check urine for protein. EKG, patients with hypertension should be screened occasionally for ischemic heart disease, which can often show up on an EKG, or left ventricular hypertrophy, which also would show up on an EKG. And also cholesterol is important to check in these patients. So, guidelines for treatment. The JNC8 just came out with new guidelines. They didn't make any huge changes from JNC7. And there's a figure that I wanted to include, but it was too big and you wouldn't have been able to read it. So basically, the change from the previous guidelines is that patients who are over 60, they've increased the blood pressure goal to greater than you want their blood pressure to be less than 150 over less than 90. It used to be less than 140 over less than 90. So basically, the research has shown that we don't need to be as tight with the control on the patients that are over 60. It's harder to control. A lot of times it would mean many different medications that have many side effects. So they've recommended that we back off a little bit on these patients. However, if they have comorbid conditions such as diabetes or chronic kidney disease, that's nullified. So still you want to be as aggressive as you would with anybody under 60 if a patient has diabetes or chronic kidney disease as well, which a lot of them do. So the first step in managing these patients, and probably the step where nurses play the biggest role, is lifestyle interventions and teaching. And we'll go through that. And then there's in this table, it also talks about which types of medications you should start with and things like that, but we'll go through that. So this is another table that kind of outlines this. So this table, just to break it down, it shows at the top, it shows the JNC8's 2014 hypertension guidelines, and it compares them with other guidelines that are used out there. But JNC8 is usually the one that people go by. So greater than 60, the goal is less than 150 over less than 90. And then it's different for patients with diabetes and chronic kidney disease. So lifestyle modifications, what do we mean about that? So here is a table of the different lifestyle mods that can help a patient take charge of their own health and try to reduce their blood pressure on their own without medications, which a lot of patients are resistant to start medications. So if we give them the correct teaching on what they can do to avoid medication, this is it. So the biggest factor is weight reduction. If they have a normal body weight, if they are able to maintain a normal body weight, that can decrease their systolic blood pressure from anywhere from 5 to 20 millimeters of mercury, which is pretty significant per 10 kilograms. So that's the biggest thing is treating obesity. DASH diet, we've all learned about that in nursing school. Dietary modifications to treat hypertension. So the diet is rich in fruits, vegetables, low-fat dairy products, and a reduced amount of saturated and total fat, and that will decrease the blood pressure anywhere from 8 to 14 millimeters of mercury. Dietary sodium restriction, that's usually the thing that we think about the most, but it doesn't do as much as the DASH diet and weight reduction. So, but I've found, and a lot of you probably found that patients will say, "Oh, I don't add any salt to my food," but that's not the problem. Our society's diet just intrinsically has a ton of sodium in it. So any processed food, anything in a can, anything that has to be preserved is preserved with sodium. So just kind of teaching patients that. For instance, I'll have a conversation with a patient. Oh no, I don't add any sodium. Well, what do you eat? On a daily basis. Oh, I eat a lot of soup. So they don't kind of make that connection that the soup has a ton of sodium in it as well. So that's a huge teaching point for patients. Increasing physical activity, obviously, aerobic activity will decrease their blood pressure, and also reducing alcohol consumption. So let's talk a little bit about medications. The first line for a lot of patients without compelling indications, and I'll tell you what that means later, is a thiazide diuretic such as hydrochlorothiazide or clothalidone. Basically, it works to increase the excretion of sodium in by the kidneys, and subsequently water will go with that, and it decreases the blood volume and decreases blood pressure. Common side effects include frequent urination, dehydration. It can exacerbate gout and electrolyte imbalances. So, if patients call and are complaining of some of these things, it's not necessarily a reason to discontinue the medication because it's a common side effect, and instead they can just, schedule a follow up with their provider sooner than their regularly scheduled one. There's loop diuretics such as Lasix or torsemide. They're typically more potent than thiazides and often used for the compelling indication of left ventricular dysfunction, patients who suffer from fluid overload, things like that. Um, so the next commonly prescribed class of medications for hypertension are ACE inhibitors such as lisinopril, fosinapryl. They work on that renin-angiotensin cascade. Common side effects are dizziness with sudden position change, a cough that would be developed by taking lisinopril or fosinapryl would require that medication to be discontinued and changed. That's a pretty common adverse effect from the ACE inhibitors. And teaching patients about the dizziness with the position change, that's normal, especially at higher doses, and to just educate them to just be careful with position changes often leads to better compliance, because if patients feel that and they haven't been told that that's a side effect that can happen, they'll just stop taking it. You need to monitor these patients for elevated potassium levels. And then there's the angiotensin 2 receptor antagonists, such as the sartans, so valsartan, Diovan, losartan, Cozar. Patients who develop a cough on ACE inhibitors can be switched to these medications. They also work similarly on the renin-angiotensin cascade, also can cause elevated potassium levels. So then there's the calcium channel blockers. There's two different kinds or classes of calcium channel blockers. Amlodipine, nifedipine, those are called dihydropyridines, and they reduce the systemic vascular resistance by blocking the peripheral smooth muscle contraction around arterioles. So they work more peripherally. Common side effects are edema, which makes sense if you think about it. If it's dilating or allowing the blood vessels to dilate, more fluid can seep out if there's too much fluid on board. These can lead to reflex tachycardia, which is something to monitor in these patients. Then the non-dihydropyridines, they have more of an effect directly on the heart. So medications like diltiazem or verapamil. So they, particularly verapamil, works more on the heart to reduce cardiac output and myocardial oxygen demands. So those medications, while they do have a little effect on blood pressure, they're more used for coronary disease management and treatment of arrhythmias and things like that. Whereas diltiazem kind of does a little bit of both. It works on the heart, but also works systemically and peripherally. Beta blockers and I guess my alpha didn't translate over. So there's beta blockers and alpha slash beta blockers. So examples of beta blockers are metoprolol, atenolol. They block receptors in the smooth muscle and the heart muscle, airways, arteries, and kidneys that are activated by catecholamines like epinephrine and norepinephrine. Common side effects of these are fatigue, bradycardia. They can actually blunt the symptoms of hypoglycemia in diabetic patients, so you have to be careful in using beta blockers in diabetic patients, and also teach them that their symptoms of hypoglycemia might not be as pronounced as they had been in the past. But beta blockers are also not a good option for patients with COPD because it can exacerbate COPD with the way that it works on the receptors. Combined alpha and beta blockers, examples of that are carvedilol, labetalol. In addition to everything that the beta blockers do, they bind to the alpha receptors in arteries and block constriction. They have a similar side effect profile. And then there's strict alpha blockers such as doxazosin and terazosin. Again, they block the constriction of peripheral arterioles. Side effects include dizziness and weight gain. Dizziness is a pretty common side effect. These are also used for BPH. Some less common agents, central acting alpha agonists like clonidine. They bind receptors in the brain that lead to reduced peripheral vascular resistance. These can cause dizziness, drowsiness. And these, the central acting alpha agonists should not be abruptly discontinued because it can lead to rebound hypertension because it's working centrally on the brain. So patients should be advised not to abruptly discontinue them and instead ask the provider on how to taper off of them if they need to stop. Then there's direct vasodilators such as hydralazine. It basically causes smooth muscle relaxation that reduces peripheral vascular resistance. These are not definitely not first line. It's more of a kind of an emergency thing, or if somebody has maxed out all of their other medications, because it's short acting. It's not a long term management kind of thing. It can lead to reflex tachycardia and increased cardiac output. So not good for patients who have coronary disease or angina. So in choosing medications, you have to look at these quote compelling indications. So a patient who has just had a heart attack, you would definitely want to use a beta blocker and an ACE inhibitor as opposed to going right to a diuretic, which is typically the first line in somebody else who doesn't have that. A patient with diabetes, basically any of these things, but you're going to want to use an ACE inhibitor most likely to protect their kidneys. So this is a kind of neat chart for compelling indications. So luckily at Harbor Health, we have a couple of really great resources that not a lot of places have, such as clinical pharmacy. So clinical pharmacy will sit down with your patient, talk to them about medication adherence, which is a big problem. Countless times patients come in and they're prescribed a medication that's twice a day, and they're afraid to admit to their provider that they're only taking it once a day because they can't remember. But somehow clinical pharmacy manages to get this information out of them. So they assess medication adherence. They do tons of teaching. They assess for adverse effects and document them, and they help with adjusting medication regimens. Their visits are no cost to the patient. There's no copay. So if there's a patient, that you want to be seen more frequently, but the patient is resistant because they don't want to keep paying a copay to see you, to see the provider, they can be booked with clinical pharmacy, kind of as an adjunct, and they're excellent. Also, because nutrition plays such a huge role in hypertension, we can refer them to the nutritionist to help reinforce dietary modifications, the DASH diet. And it's very patient centered. Patients can go online and look up all these things, but meeting with the nutritionist one on one, they can kind of tailor their meal plan to things that they like and to their lifestyle and all of that. So it's a really great resource that we have here. So let's just talk about triaging some hypertensive crises that I'm sure will come up on the phones. So there's hypertensive urgencies. So patient calls in, my blood pressure's 160 over 100 over the last couple of days, but I feel okay. I don't have any headache, I don't have any chest pain, I don't have any shortness of breath, but Stacy told me to call if my blood pressure was running high at home. So they should be offered a same day or next day visit with a provider, but they don't necessarily need to be, sent to the emergency room if they're not having symptoms, they're not having swelling in their ankles, things like that. No evidence of acute target organ damage. On the other hand, a hypertensive emergency, patients who are calling in or presenting as a walk-in with evidence of acute target organ damage, labeled as malignant hypertension. So a severely elevated blood pressure over 180 over 120, evidence of target organ damage such as a really bad headache, chest pain, shortness of breath, any of those things. Obviously, you're going to call 911 or you're going to have to tell that patient to go right to the emergency room. So these are kind of the typical NIH recommended monitoring parameters. So if somebody has a normal blood pressure, check them every 1 to 2 years. Somebody in pre-hypertension range, definitely want to check them yearly. Somebody with stage 1 hypertension, you want to confirm within 2 months. I would say 1 month. If somebody has uncontrolled blood pressure, they should be seen monthly until their blood pressure is well controlled. Somebody with stage 2 hypertension, you're going to be making an intervention. You're going to want to see them in 1 month, if not sooner. If I make a medication adjustment, I'm going to want to see them in 2 weeks likely. If their blood pressure is very high, so over 180, over 110, I'm going to want to see them in a couple of days or in a week. If they're asymptomatic. If they're symptomatic, they're going to the hospital. So here are a couple of resources. A lot of times patients like to take something with them to talk about it at home. Up to Date is a great resource. They have tons of topics that you can print out for patients, and it's not all the medical jargon. They have patient-specific handouts. You can find this in NextGen. If you go under the Utilities tab, Up to Date is right in there. You could just basically search for any topic. So you could search for DASH diet, you could just search for hypertension, any of those things, and print out a nice patient-centered handout that they can take home with them, read about it, things like that. And then there is this, Tufts has this website called Spiral, Selected Patient Information in Asian Languages, and they have a lot of topics in Vietnamese, which is and other Asian languages, but Vietnamese is one that we'll be using a lot. So definitely use those if patients are asking you questions. And then just to touch on adherence and the huge role that we play in these patients. We're all a team, as we've been talking about for the last several months. That if each player in the team is not pulling their weight, there's going to be a breakdown in the treatment. So, where nurses come in huge is the communication between the patient and the provider. You are that middle person and the front lines. So oftentimes patients are going to ask you questions, and and if they're not getting the answers they want, they're less likely to have trust in their care, and not. They have more likelihood that they're not going to be adhering to their treatment regimen and things like that. So you all should be applauded for the work that you do, because it's so important in helping us care for these patients. And thank you for all that you do.